Welcome to our weekly Zoom news conference. I'm Sandy Close, Director of Ethnic Media Services, joined by my colleague Pilar Marrero and Sunita Sarabji, who together organize these weekly briefings. Today, we focus on the mental health challenges confronting youth, which U.S. Surgeon General Vivek Murthy, in a rare warning this week, called an emerging crisis exacerbated by pandemic hardships. Our speakers will present an overview of the crisis, along with data on mental health indicators and perspectives from particularly vulnerable populations. Our presenters include Michelle Doty Cabrera, Executive Director of California's County Behavioral Health Directors Association, Laurie Bisoxi, Senior Program Director for Kids Data, an initiative of the Population Research Bureau, Latonia Wood, Director of Clinical Training at the Graduate School of Education and Psychology at Pepperdine University, Ulash Thakur Dunlop, a marriage and family therapist and board member of My Sahana, and Gabii LeGate, Director of Blossoming Minds. Today's news briefing is presented in collaboration with the Center Sierra Health Foundation and the California Department of Public Health, which have both been strong promoters of ethnic media coverage of the pandemic and vaccinations since the pandemic began. We ask our speakers to speak slowly, as I am doing, for our interpreters in Spanish, Mandarin, and Korean. We urge our media colleagues to enter questions in the chat box, and we hope our speakers will monitor the chat and answer any questions they feel they can answer on the chat. We will send expanded bios and a video of the conference later today, along with a report in several weeks of the coverage this briefing has generated by our great media colleagues. So now I turn the conference over to Associate Editor Sunita Sarabji. Sunita.
Thank you so much, Sandy, and welcome to our speakers and to the media today who have joined this call. Very important call. I think over the past 22 months, a lot of our parents have looked around and said, what's going on with our kids? We are at home with them 24 hours a day, and we see the changes firsthand in their behaviors. And not sure that we have the perspective necessarily to deal with the challenges that come along with that. So we welcome our speakers today to add their perspectives. As with COVID, we know that mental health also is divided along equity lines, socioeconomic lines. And so we invite our speakers to also add some perspective about that. So we start off with Michelle Doty Cabrera, who Sandy has already introduced. Welcome, Michelle.
Thank you, Sunita and Sandy, for the opportunity to share some perspectives with you today. I am the Executive Director of the County Behavioral Health Directors Association. We are a nonprofit association representing the behavioral health directors for all 58 California counties, as well as 2 city mental health authorities in Berkeley and Tri-City area of Los Angeles. The County Behavioral Health Safety Net is a public safety net for adults and children with serious emotional disorders or serious mental illness, as well as substance use disorder needs. And the safety net primarily serves those individuals with Medi-Cal, although we do have resources that extend to additional services as well as populations. In addition, under Medi-Cal, the state has Medi-Cal managed care plans that also serve children and adults with less severe mental health needs under a mild to moderate mental health benefit. Medi-Cal offers no cost coverage to low-income children, regardless of immigration status, as well as families, and covers nearly 40% of all California children, or 1.3 million children and youth. Today, we are talking about the significant mental health crisis among children and youth in California and nationally. As discussed, our U.S. Surgeon General's advisory was released this week and demonstrates that children and youth throughout the nation, including in California, are suffering. The pandemic has been especially hard on children and youth. And during the pandemic, our county behavioral health safety net, which helps to manage crisis services for a large swath of children and youth, reported that the numbers of children and youth in acute mental health crisis shot up 2 and sometimes 3-fold. We have had children as young as 8 years old who have been hospitalized due to suicidal ideation. And our behavioral health directors report that, consistent with historic trends with youth crisis, that when students transition back to school in person, this actually results in higher rates of children and youth experiencing mental health crisis. So there's sort of a two-pronged issue here. Having students away from school and social and emotional supports in school exacerbated mental health crises, but when children come back to school, we actually see higher rates of crisis. The issue of children and youth mental health and substance use disorder needs is not an easy or straightforward one. When it comes to behavioral health, children and youth are not simply little adults. Clinically, emotionally, and in terms of treatment, they are different and they require different resources and approaches. Identifying emotional disturbance is a complex issue, and children rely often, and I consider teenagers in this category, often rely on the adults in their life to help them seek care. We know that today, not all primary care clinicians screen for behavioral health conditions, nor do they have the specialized education and training to accurately identify, diagnose, and connect those youth with the services that they need. All of this can result in delays of necessary care. And although not all youth who experience trauma have a mental illness, we know that youth who have experienced significant levels of trauma, including the emotional toll of racism, should be provided with extra support, including behavioral health supports, to mitigate the potential for anxiety, depression, and PTSD, which can result from these experiences. I will speak a little to the disparities that are known, particularly in the public system, which I represent and can speak to. If you look at the data around children and youth who are served in Medi-Cal across both the specialty mental health services delivered through counties, as well as the non-specialty services delivered by managed care plans, the State Department of Health Care Services stratified those data by race and ethnicity, and we can see some alarming disparities that must be addressed if we are going to achieve equity and eliminate disparities in access to culturally congruent care. When adjusted for population, The county behavioral health system disproportionately serves Black and Native American children and youth, and underserves Latinx and API communities within the Medi-Cal population. Conversely, our Medi-Cal managed care plans serve a disproportionate number of white children and youth in Medi-Cal. Stigma is, of course, a challenge within BIPOC communities, and that is something that can be overcome both within healthcare systems by ensuring access to more culturally congruent services. That means workforce who reflects the community served, who have the linguistic but also cultural capabilities. And in addition, County Behavioral Health has heard from our communities that they do not always want to access the medical model types of treatment. And so we are very lucky in California to have funding sources that go beyond the medical model, such as the Mental Health Services Act, to provide some of those culturally defined practices to reach into those communities. But clearly, much more needs to be done, particularly with respect to our Latinx and API communities. And I just want to mention that the fact that we have more Black children and youth served in the specialty mental health system, it is a reason to sort of ask questions. We know that often there have been studies that show that individuals are more likely to be misdiagnosed with schizophrenia as opposed to other mood disorders if they are Black. And so some of this may be inappropriate, but again, we also know that the stressors of racism and other systemic issues also could be driving some of that severity. I do want to say that help is available, and Medi-Cal plans are required to provide timely access, transportation, and interpreters for those services. During the pandemic, we have greatly expanded the availability of mental health services through telehealth. Although telehealth is not always ideal, particularly for low-income families who may live in close quarters and so not have the privacy needed for a telehealth visit, or because of the digital divide. And overall, as with other sectors, we are experiencing a severe workforce crisis in behavioral health. I do want to say that there has never been a better time to look at careers in the behavioral health workforce, and California is bringing on new benefits, including a new community health worker benefit and a new behavioral health peer benefit in 2022. I want to call out substance use disorders because we know that the pandemic has had a pretty significant impact on alcohol and drug use. A study by RAND this year found a 40% increase in heavy drinking among women in the US during the pandemic. This comes also after news around the opioid epidemic, both nationally in California. There has been a nearly 29% increase in the use of, or in the opioid-related deaths, and 64% were caused by the synthetic opioid fentanyl. Fentanyl is often laced into other street drugs, and so we're seeing higher rates of young people with fentanyl-related overdose deaths who don't know that they are consuming fentanyl, and more public awareness is needed about this crisis. I mention these statistics because the co-occurring mental health and substance use disorder rates are much higher for teens. Teens with co-occurring mental illness and substance use disorders are at 60 to 75%. The state has made an historic investment in behavioral health this past year with a $4.4 billion children and youth behavioral health initiative that includes funding for more school-based services, school-based coaches and counselors, mobile crisis infrastructure, as well as additional evidence-based practices such as early psychosis programming. Adults should not despair. There is hope, because when youth are connected to effective interventions, they are extremely receptive to that, resilient, and we can prevent long-term chronic behavioral health conditions. But we need to pay attention to young people, to listen, and to take action to connect them with help. There is a new parity law in California that requires more of plans, health plans. There is a new Department of Managed Health Care helpline where individuals can file complaints if their plans do not help. And there is also a text and phone line service available through the state called Cal Hope, where individuals can reach out to access emotional support. Bottom line is reach out to your physician, your health plan, or to your county behavioral health agency sooner than later to get help.
Michelle, thank you so much for your remarks. I know you have an 11:15 cutoff, but there is one important question from Henrietta Burrows that I'm hoping you would address before you leave. Henrietta, could you please ask your question?
Thanks so much, Sunita. Yes, you had mentioned that children have emotional problems that are exacerbated by going back to school. And many people thought that going back to school would be a very positive experience where children would get to meet their friends and have a chance to socialize. So why is it that their emotional issues might be exacerbated when they go back to school?
You know, we don't have a clear answer, but we have some guesses from our clinicians. And one of the guesses is that it really is different for different populations of youth. So some youth, such as LGBTQI youth, may find it very difficult to be at home if their family is not supportive. We saw extremely alarming, striking rates of suicidal ideation among LGBT youth during the pandemic. For children for whom the home is not a safe place, where there is domestic violence or neglect, that is a really hard place for them to be. And we actually suffered a lot in that we did not have mandated reporters able to connect those children and youth with help during the pandemic. We couldn't see them. We didn't know that they were in trouble unless they somehow figured out a way to reach us. So that population of children and youth suffered greatly by not being in school. The flip side is when children and youth go to school, they do experience social pressure or other kinds of bullying and engagement within the classroom, whether it's with, adults who may treat them unfairly, discrimination, bullying, those sorts of things that may also result in crisis. And so it's really just different issues that arise depending on where they're at.
Michelle, thank you so much for joining us today and taking time out of your schedule. And reporters, you can follow up with Michelle. We will include contact information for each of our speakers in our follow-up material. Thank you again, Michelle. And we next move on to Dr. Laurie Burke Bichachku. I'm so sorry, Laurie. I promised myself that I would pronounce your name correctly, but I hope that's close enough. Laurie is going to present data from kids data. We welcome you, Laurie.
Thanks. I will share my screen.
There you go.
Okay. And you're able to see the PowerPoint presentation
Yes, we are.
correctly? Okay. Thank you for inviting me. I'm happy to be here. And I'm with the Kids Data Program. The Kids Data Program, we provide data and information about children's health and well-being in California on 57 different topics. And we also provide ways to understand the data and be able to use the data by drawing on dozens of different sources and make it very easy to use and access in a common format on kidsdata.org. We're at PRB, and PRB in general works in the same area of data, except across the lifespan, and we have a particular expertise in working with data from the US Census Bureau. Before we talk about mental health during the pandemic, I want to talk about mental health before the pandemic. There was already a great deal of concern about mental health leading up to the pandemic. For example, for youth suicide rate for the United States, the rate was 14 out per 100,000 youth in just before the pandemic, 2017, 2019, and just under 9. The rate was just under 9 in California. And over the dozen years or so leading up to the pandemic, the rate had been increasing. So we could expect that with the hitting of the pandemic, mental health would only become more challenging for youth. And this is in fact what we have seen. There is lots of anecdotal evidence, and our last speaker certainly shared some data findings and as well as anecdotal evidence about that many children and youth are suffering mental health issues. And I will be now sharing some additional data. The data story is still being told. Some of the pieces of evidence about youth mental health are not available yet, but we do have some, and the message is certainly clear. First, there was a survey that was put into the field 3 times, asking parents about a host of experiences about their experiences during the pandemic. And they were asked about their level of concern about their children's mental health. Across groups, there was great concern about their mental health, but for Hispanic Latino parents in particular, half of Hispanic Latino parents were at least moderately concerned about their children's health, their children's mental health. But across each race ethnicity group, at least 1/3 of each group were at least moderately concerned. A doctor shares with us, a psychiatrist, Dr. Marcus from Alta Bates Hospital, that there has been an increase in prevalence and intensity of mental health problems in our young people. She has seen amplified symptoms of depression, anxiety, and eating disorders, and more, and it really does feel like a crisis. Overdose deaths is a particular compelling, just tragic statistic that we are seeing. And this was addressed by our previous speaker too. She talked about drug misuse. 282 young people in California died by overdose in 2020, and 12 died who were ages 10 to 14. This is a dramatic increase from previous years. And in fact, among the youngest age group, 10 to 14, the rate was 0 and now 12. So we see the really, the tremendous impact that's happening. And talking more about the US emergency department visits for mental health. From the US perspective, the proportion of children's mental health related emergencies when they go into the emergency room has been increasing. So taking a time period compared to 2019, for teenagers 12 to 17, the proportion that were going into the emergency room for mental health care increased by 31%. And for ages 5 to 11, the proportion increased by 24%. For ages 0 to 4, the proportion remains similar. Another statistic about emergency room visits, about suicide attempts. Initially, after the the pandemic started from March, April, the rates for suicide attempts that ended up in the emergency department decreased, but then from May onward, they have been increasing. So taking a time period, February, March 2021, and comparing that to the same time period in 2019, there was an increased rate of 51% among girls going to the emergency department because of attempting suicide, and a 4% higher rate among boys. So we see from the data and anecdotally that there is a great deal of concern about mental health. We know it's there. It's been acknowledged nationwide within California across the board. But providing the services is another part of the story. And even before the pandemic, the services, not all youth were able to get the services for their mental health conditions that were needed. And now the need is even greater. A psychologist in the San Francisco Bay Area noted that mental health providers have been inundated with referrals. I did call around to a number of mental health, actually I should say intensive day programs in the Bay Area. And these were intensive day programs specifically for depression and for eating disorders. Typically, there was a 3-month wait to get a spot in one of those programs. The least amount was a 2-month wait. What is a parent supposed to do if they can't find help for their children? I know other speakers will be talking about this much more, but this is really, I'll just have to say that this is I'm dealing with this in my own family. So it is very difficult to find the help, and it's just very challenging. I'll leave it at that. It's my daughter's story to tell. I have a 15-year-old at home. She is one of the statistics. For the rest, I'm not going to go through this, but you'll be receiving these slides. There are a number of links here to that really address this issue of mental health and well-being among children in the United States and in California. I do want to point out a couple of pieces. For the California reports, we do compile reports, key findings, key reports, important websites within each topic. And so rather than provide it on this, provide it here, I do provide the link so that you can see that compilation. So I selected 3 topic areas that are most important to the topic that we're talking about today. Also, I'll point out that a number of indicators that we have on the website do directly relate to this topic, except we only have the pre-pandemic data so far. So I list the indicators here, which they're all hyperlinked when you receive it later. And as soon as we have the updated data, we certainly will update it so that it will become available to all of you. Later, I didn't think to put it on the slide here, but later I'll put it into the chat. We do put out a notice twice a month so that you will be able to know what is the most recent data that we're releasing about children's health and well-being. And so when these that you see here are updated, it will become a part of that notice. So if you're interested in receiving that twice a month, then I will put the link in the chat box so that you're able to receive that notice as well. I want to thank you very much. I know this is just a very brief data highlight. There is so much to be told, so much to do. So thank you very much for allowing me to be a part of this conversation.
Thank you so much, Laurie. Joseph Orozca asked a question about, he did not see an indication for Native American youth, and I'm wondering if you have data that you could share with him.
Not at this time. Native American youth, oftentimes, I'm talking about indicators in general. The data are often suppressed, which just always hurts my heart because the population is small. What we do to provide more information about data about Native Americans is we'll combine years so that across perhaps 2 years or 3 years, we'll have enough information to reliably show findings And so just now the 2020 data are coming out. My suspicion is we might need to wait a little bit longer so that we're able to have enough data to be able to share. So I'm very sorry I'm not able to share for Native American youth. I can say anecdotally, it's a population that tends to have greater challenges, but I don't have the data to back it up.
Laurie, thank you so much for joining us today. We very much welcome your remarks. And reporters, we will send out Laurie's slides with the follow-up materials after the briefing. We next welcome Dr. LaTanya Wood from Pepperdine. Dr. Wood, welcome.
And do I need to unshare my screen, or are you able to do that so we can not see my screen anymore?
Oh, you don't need to share your screen anymore.
Okay.
So yeah, I think you have to stop the sharing function because we're still seeing your screen. Yeah.
I thought you'd take it back from me.
Let's see. I'll go ahead and get started. So thank you for the invitation. And as the previous speaker just mentioned, even before COVID, and again, I should introduce myself more formally as well as my topic. So as was mentioned at the start, I'm the Director of Clinical Training at Pepperdine University and the PsyD program, as well as the past president of the California Psychological Association. So with some of the data and the anecdotal data that we have already heard this morning, I want to look more specifically in the African-American community with Black youth. And as the previous speaker mentioned, the pre-pandemic mental health needs that were already, we were seeing an increase in, that was especially true in terms of depression and suicide rates of Black youth. In the last 2 decades, we've seen some sort of alarming rates of increase of suicide and depression. Some 2018 data found that Black children between the ages of 5 and 12 are about twice as likely to die by suicide as white children of the same age. And some of the variables attributed to these higher rates seem to be linked to experiences of adverse childhood experiences within the community. So things like loss and separation from family, interpersonal trauma, abuse, experiences of racism and discrimination, as well as lack of access to care. And I think it's also important to note that the symptoms and red flags that we traditionally use to assess for suicide and depression often and may very well look very differently in Black youth. So rather than sadness or hopelessness, Black males in particular may express irritability and anger. Depression is often manifested or expressed more through physical or health complaints. So talking about feeling tired or fatigued or having body aches and pains. So I think it's not only the availability of care, but as was talked about before, the getting an accurate diagnosis and accurate assessment so that there's a connection to mental health care for these children and youth. And COVID sort of amplified all of that. And I think in reflecting on the Black community, particularly in Black youth, I think 2 things sort of happened simultaneously. First, COVID exacerbated the existing vulnerabilities and risk factors for suicide and depression. As we know, African Americans were disproportionately affected by COVID medically with more severe health outcomes. And that medical impact was felt not only by adults, but by youth as well, who were 2.5 times more likely to be hospitalized than white youth and 5 more times likely to die from COVID. So in addition to grappling with the grief and loss of loved ones, Black youth rightfully were also experiencing an increased fear and anxiety about their own health and well-being. There was a loss of income in households. So then there was also increased concerns about finances, as well as increased food insecurity. With school closures and shutdowns, we saw an increase in vulnerability and exposure to abuse and trauma. And not to mention the social political unrest the summer of 2020 and the ongoing racial trauma experienced in this country that our Black youth were exposed to as well. So all of those increased the vulnerability and risk factors they were already experiencing that were contributing to the high rates of suicide and depression. And then the second thing that also was happening is that the public health measures put in place, understandably, to mitigate the effects of COVID, tapped into the very sources of coping and strengths that Black families in particular use to cope and survive, particularly during times like a pandemic. So in his book, The Strength of Black Families, Robert Hill identified 5 characteristics or traits that really facilitate the strength and resiliency of Black families. Things such as strong kinship bonds, so taking care of family and kinfolk, a strong orientation to work, so strong work ethic and a desire to work, a very strong achievement orientation, so wanting to do well, and a strong religious orientation, and really seeing the religious and spiritual community as a source of comfort and strength and support. And so in this move to distance learning and social isolation and shelter in place, it stripped away the very tools that Black families and youth historically have leaned upon to survive. You know, adolescents experienced decreased connection with family and with peers and from their religious communities. The educational gaps that already existed were widened during this time. And then, of course, there were the barriers to mental health that already existed that, again, got sort of amplified during this time. And in thinking about those barriers to care, some of the consistent themes that we continue to see are first and foremost the financial cost of getting health care, mental health care particularly, and especially during COVID, when families did not have disposable income to seek and receive mental health care. There's also a historical and cultural lack of trust in providers in the mental health and in the providers in mental health, but providers broadly within the Black community. And a survey sort of asking Black youth and adolescents about mental health care during COVID reported that they feel that providers don't care about them. They're only concerned about money. They don't understand their lived experience, and they're not relatable. And I think that really reflects the lack of culturally informed and trauma-informed care, and really understanding that the experiences of Black youth were in some ways traumatic during COVID. And there's also the lack of representation and availability of Black therapists. A 2020 workforce study completed by the American Psychological Association revealed that just short of shy of 4% of psychologists in the United States are African American. And I, personally speaking, I can say that during the pandemic, we have been overworked. And my own practice, I, for the first time, probably had a 10-fold increase in referrals, specifically from people of color, clients of color who were seeking therapists of color. And we're having a very hard time finding therapists of color. And I think there was some hope that the use of technology would increase access to care, but that also came with some challenges. And just to kind of sort of share a personal anecdote from my work as the director of clinical training at Pepperdine, I do some supervision, and we provide no-cost services in South Los Angeles, specifically for families and victims of crime and trauma. And one of the cases that we had is a family in South Los Angeles. It's an African-American adolescent female who had had some recent losses, some COVID related, not all of them, and also had her own physical health issues, was struggling academically in part because of the distance learning, and so was referred for services to our clinic. And so while there were no longer the financial barriers to access to care, and in some ways, the technology in doing telehealth also prevented the reliance on transportation, which sometimes were challenges for families as well, who relied on public transportation to get to our office. The family did not always, the client and the family did not always have devices available to use. So we didn't know if it was going to be a phone or a school issued laptop or a tablet. So there were often connection issues, as well as there were several family members living in this home. So privacy during sessions virtually was impossible. So it was a bit of a mixed bag in terms of truly creating the environment for the client that we felt was optimal for her. So in conclusion, I just want to say this is very complex. And I think strategies to address the disparities that we see in rates of depression and suicide in Black youth, as well as the underutilization of care, really needs a thorough review and comprehensive evaluation of the social, cultural, economic, and environmental determinants of health, as well as those barriers to access to care that so many of us have already discussed this morning.
Thank you, Dr. Wood. One question that came up is, what do parents do when it takes 3 months to get that initial appointment?
That is a great question. I don't know that I have an answer for you. Anecdotally, in my own private practice, I recently accepted an adolescent client. I haven't seen adolescents in several years, but it basically was, we have this Black female and we have been looking for months and we can't find anyone. So I think that they just exhaust all resources and connections and efforts. And my concern with that is that, the loss of quality of care in that process, right? Like, in the search for seeking someone and in that desperation, just anyone. And that was, for me, I was motivated by, I want to make sure this child gets good quality care, and I'm worried of what will be left. So unfortunately, not very much. I think Dr. Turk B. Kaki just put in something. I think the emergency departments get utilized for this. I think the schools are grappling with this. I think they're saying increased referrals in the school settings as well.
Thank you so much. And if you'll stay on, there are more questions. We're going to run over a little bit, and I hope reporters stick with us for the end of this conversation. And we next move on to Dr. Ulash Thakur Dunlap. Dr. Dunlap, welcome.
Thank you, everyone. Thank you, Sunita and Sandy, for the opportunity to speak to the specific challenges as it relates to Asian teen mental health. So I'm current full-time faculty at the Wright Institute Master's Counseling Program, and also part of my Sahana, which helps to reduce mental health stigma and provide resources to our South Asian community here. After more than 20 months into the pandemic, many of our teens in California have been back at school since September. But our Asian youth have had to deal with so many challenges while they've been trying to navigate their mental health and well-being. We know that the racially motivated attacks in our Asian community and being blamed for the spread of the COVID-19 have left many of our Asian youth feeling the racial trauma by either witnessing their parents being verbally or physically abused, or their Asian teen has actually been a victim of these racially motivated attacks. AAPI individuals said the racism they experienced during COVID-19 was greater than the stress of the pandemic itself. According to Stop AAPI Hate Mental Health 2021 report, hate incidents jumped from 3,795 in March 2020 to 6,603 June, March 2021. Things that were reported were verbal harassment, 65%, and shunning, 18%. Those were the two common types of incidents. The impact of these racialized experiences have impacted Asian youth's distress and many strongly associated symptoms from the experiences of those of post-traumatic stress disorder, to include feeling irritated, hypervigilant, and afraid. Our Asian youth are carrying these traumatic stresses as they are now back in schools, trying to learn, navigate being back at school with their friends and with their family, as well as dealing with racial trauma. The anti-Asian hate and racially motivated attacks have left many of our teens feeling anxious and worried about their parents. In the Society for Research on Child Development September 2020 statement, they found that 65% of Chinese American children and adolescents and over 75% of parents reported being worried that they will suffer from being blamed from COVID-19. Some of our speakers have also talked about suicide. There have been concerns of suicide during the pandemic. According to the Center for Disease and Control and Prevention, suicide is the leading cause of death for our AAPI ages 15 to 24-year-old. That's very a unique distinction among other racial and ethnic groups in the United States. There are many factors to consider in our Asian youth, to include having access, like my peers have shared today, of mental health services, the cultural and language barriers for our Asian youth, as also they are caught between the pool of family tradition and open discussions about mental health with their families. Asian youth may want mental health services and have to struggle, as we've been speaking to today, about getting help, and also for parents understanding the importance of counseling and mental health for their well-being. We've also noticed for our immigrant youth the acculturation stress during the pandemic and the conflicts as they are navigating two different cultures. And this has actually been indicated as a suicide risk factor as well as—
Lush, just a little bit slower.
Yes, sure.
Thank you.
You're welcome, yeah. So it's also increased the risk factors of suicide as well as anxiety and depression. So for many of our teens, as some speakers have mentioned, school is a safe haven and a protective factor. But for those Asian youth that were experiencing domestic violence at home, they weren't able to actually see their therapist at home. And so their stress has just really increased for some of our youth. So again, a small percentage of our teens are self-harming as a way of coping with these stresses. So to kind of conclude then, going back to person as an Asian teen, the anti-Asian hate, the isolation from friends during the pandemic, and the lack of supportive services also as they were transitioning back to school have really impacted Asian youth psychological distress, academic achievement, and engagement with their schools and peers. So if we are going to talk about some of the barriers right now in accessing mental health, the National Latino and Asian American Study 2021 reported that 18% of the general US population sought mental health resources, while 8.6% of our Asian Americans sought counseling services. And there are many reasons. The pipeline is a problem in terms of lack of representation of Asian American providers who represent our community. Like Dr. Wood shared, active psychologists right now, according to the American Psychological Association, 84% identified white, but 4% AAPI. And that's very similar for counselors and social workers. So having providers, specifically Asian American providers, is very important in working for youth, especially for our parents to help access services, feeling understood and supported. Studies have highlighted Asian American immigrants experience discrimination while visiting their healthcare providers. And this has left many teens, Asian teens and families being kind of not wanting to go back because of the experiences they've had. Finally, there's a lot of shame and stigma in accessing resources for our Asian families. Although second and third generation Asian youth are more than likely to seek out and want counseling, parents may be reluctant to share concerns and problems with providers. I feel that problems can be dealt at home, and then it can bring shame in terms of getting support outside. So just to wrap up, what can we do for our Asian youth in our communities? I believe it's really important for staff, whether they're Asian identified or not, to really understand the nuances of being an Asian teen and how teen cultural background really does impact our Asian teens. We need to have more pipeline programs where we can have actually more Asian counselors to serve our Asian youth. So we do need to diversify the workforce. And again, now we have this problem, right, of not having enough counselors like my peers have shared. So how can we train our therapists and counselors and psychologists around some cultural competency training around working with our Asian youth and families? And given that our children spend and our adolescents spend more than 6 hours in schools, how can we spend more money in having more counselors at schools and mental health providers? Thank you.
Thank you, Ulash. There was a question from Sandy Close, actually. Is there a gender divide? And actually, Dr. Wood, if you could address this question as well. Are girls, young women, more likely to self-harm and commit suicide than boys are?
Are you addressing that directly to me or?
To both of you.
Oh, okay. So the data that I looked at in the Black community is that there are higher rates of attempts and maybe self-harm by girls, yet boys, there's a higher rate of actual completions of suicides in boys.
Yeah, that seems to, thank you, Dr. Wood, that seems to be very similar within the AAPI community around the attempt rates are higher for female identified clients, but the completion rates are much higher for male identified clients.
Thank you to both of you. We move on next to Gabii LeGate, the Senior Operations Director of Blossoming Minds. Gabii, welcome.
Thank you, Snita. Thank you guys so much for having me today. As mentioned, my name is Gabii. I am the Director of Operations for Blossoming Minds.
And you're gonna have to slow down.
So sorry. For Blossoming Minds, which is an up-and-coming educational community-based organization that works to create and cultivate a future where students can engage in thoughtful and respectful discussions about social issues while feeling empowered to stand up against social injustice and mistreatment. Recently, we've been creating our first set of education curriculum, which is focused on mental health, and I'm really excited to continue that conversation here. Today, I will be talking about personal mental health struggles in the pandemic, as well as statistics and stories of others, and framing the pandemic and the struggles of it in a LGBT context. I want to preface this by saying that all of the statistics I share today will come from the Trevor Project's most recent national survey, which was taken in 2021 during the COVID-19 pandemic. So I want to begin by sharing that in the last year, 70% of LGBT youth stated that their mental health was poor most of or all of the time during the COVID-19 pandemic. 42% of queer youth seriously considered or attempted suicide in the past year, including more than half of transgender and non-binary youth. This is up 3% from the 2019 national survey, and I can drop those statistics a little bit later. The effects on communities of color are much higher than white counterparts, with 12% of white youth attempting suicide, compared to 31% of Native and Indigenous youth, 21% of Black youth, 21% of multicultural youth, 18% of Latinx youth, and 12% of Asian American Pacific Islander youth. I'm sure that most of the general population has felt the impact of this pandemic on their mental health. And I'm sure that Most of us have struggled with depression or anxiety or a general feeling of helplessness in these last year and a half or so. Dealing with something that we know nothing about and not being able to see our friends and family is stressful. It's scary. It's daunting, and sometimes it feels like it will never end. Personally, I had a lot of milestones in this pandemic. I graduated college. I turned 21. I watched my sister graduate high school on FaceTime. And I personally don't know how I would have gotten through it if I didn't have a support system. There were days where it was hard to get out of bed, or I had to force myself out of bed. And I'm just thankful that I had and have a support system to rely on. And speaking of support systems and home life, in the last year, more than 80% of queer youth stated that COVID-19 made their living situation more stressful. And only 1 out of 3 queer youths found their home to be LGBT affirming. And just to specify, LGBT affirming household means that their household and the people who live with them are loving, accepting, and affirming to one's identity. So only 1 out of 3 queer youth had this experience. And I think that statistic is especially important to keep in mind. Oftentimes, especially with younger LGBT people, school can be a time to be with their friends and escape their home life. I will say that's not the case with everybody. Some people do experience a lot of bullying and discrimination in school, but for some, it is sort of their safe haven. If a student has a patient or a parent or a caregiver at home who is not LGBT friendly or who does not affirm their child's gender identity or sexuality, school can be a way to escape that. But now, when we are all forced and told to stay at home, learn from home, work from home, these students might be forced to stay in an environment that is dangerous, scary, and possibly life-threatening. A supportive home environment is critical to anyone, and especially to young queer people. I personally am extremely fortunate that my parents have always been extremely supportive of me. They've always known that I was queer, that my friends were queer, and they never gave me any grief for it or questioned me for it. And I will always be grateful for that. And another issue that has been brought to the forefront during the pandemic is mental health services like therapy and accessing those services. The Trevor Project reported that 48% of LGBT youth reported that they wanted counseling from a mental health professional, but were unable to receive it in the past year due to a multitude of reasons, some of which we've heard from other speakers today. One thing that I want to touch on is that people under the age of 18 and sometimes 16, depending on who your health provider is, people typically don't have their own insurance at that age. For example, in middle school, when I went to therapy, it was under my parents' insurance. They knew about it, they took me, and they were open and willing to provide me the support that I needed. But for others, the insurance barrier can be huge. Not everyone feels comfortable or safe telling their caregivers that they need therapy or mental health services. And this could be for a lot of different reasons. If a young person needs therapy because they're being bullied at school, for example, for their sexuality, and their parents have openly stated that they don't support gay people, how is that person supposed to receive the possibly life-saving help that they need? Schools do have counselors, but however, in reality, these counselors aren't always able to provide students the support they need. Sometimes it's 1 or 2 counselors for a student body of 500-600. I personally know somebody whose school could only afford to bring in counselors once or twice a term to serve the entire student body. That is not helpful or sustainable at all. So just to wrap up, the pandemic obviously has been mentally challenging for all of us, and especially challenging for LGBT youth and teenagers for many different reasons. And if you take anything from my time speaking today, I hope it's that to just be kind to one another and support any, queer youth that you have in your life. This is an incredibly hard time for everybody. So thank you again to Ethnic Media Services for having me today. I really appreciate you reaching out, and it was an honor to be here and to listen to everybody.
Thank you so much, Gabii. You brought up some really interesting points. I have a question for all speakers. Gabii, maybe you can kick it off. Khalil asks, what types of self-harm should parents be on the alert for with their children? Gabii, if you want to start.
Sure, yeah, that's a big question. Being somebody who has that background personally and who have had my parents had to go through that, I would say that a big thing to look out for is just changes in behavior. If your kid usually enjoys, watching TV with you or talking with you in the evenings after dinner, and they don't anymore, if they are not eating dinner with you guys, they say they already ate or are not hungry, that could be a sign of them not eating on purpose. And I don't want, okay, I'll just stop there. I don't want to ring the alarm bells for no reason, of course, but to me, that is a big thing to look out for.
Okay. Ulash, Dr. Wood, Laurie, would you like to address that question as well?
I think, youth use all different ways of coping. It's a way of releasing the stressors. It could be from cutting using razors or knives to using open flames. So there are very different ways that our children and youth cope, engage in self-injurious behavior.
Dr. Wood?
Sure. Yeah, I think in addition to what has already been said, sort of for self-harm specifically, change of behavior, maybe change of clothes too. Are your kids wearing long sleeves, pants, sort of covering up things? And to Ulash's point, there are different methods. So, when I was working with adolescents, and if I saw a teen getting a lot of repeated tattoos and piercings, and again, not to sound the alarm bell, but I would always, especially if it was in an impulsive nature. So a lot of repeated piercings and tattoos and things that seem to be happening. A lot of unexplained injuries. That so you're seeing some bruises and they are can't really explain. So. But primarily changes in what they're wearing, changes in their behavior, in their routines.
Thank you. Dr. Pachachi, would you like to address this as well?
I think it's pretty well covered. Change of clothing, I think, is a big one. Suddenly wearing long sleeves or baggy clothes in particular. Scissors can be used, even a comb can be used, cutting in this area, I think is common. A doctor did tell me that if a person is discovered, sometimes they'll cut at the hip, at the crease where it can't be noticed very well. And Band-Aids, where it's what's happening, or the dog is scratching me, how is it happening so often? So those would be some other things I would say to look out for.
We have one last question. Michelle has rejoined us, and I want to ask this of all speakers, beginning with Michelle. How do we move forward from here, and how do we get kids the resources and care that they need? Michelle.
Thank you. Well, I mean, I think the perspective that I bring is, from a system of care perspective. And I think that policymakers in California and nationally are showing a shift in that they are paying attention to behavioral health in a way that they hadn't before. But there's a massive systems shift that needs to come along with that, meaning aligned resources and, as I mentioned earlier, workforce, et cetera. So I think, all of that will take time. I think as consumers, people need to ask more of their health plans. This is why you're paying premiums, right? The regulators are geared up to do their piece, and we have a reasonable expectation that our health plans will step up and provide those services. But unfortunately, when those systems are overwhelmed or they don't have what you need, then the real issue is get the help where you can. Be open to the possibility that behavioral health services, mental health and substance use disorder services are actually really effective and can help people long-term, prevent them from getting worse off. Recovery works. Mental health recovery is a thing. And the final thing I'll say is that you never know when you're talking to someone who may have a significant behavioral health challenge in their life, right? We really, part of the stigma is this othering of people with behavioral health conditions and this thinking that it's sort of that person over there, or, the othering of the person who may be having a hard time in our community. Well, I can assure you, we all work with our neighbors, are in community with people with behavioral health conditions. It's as normal a thing as experiencing a broken arm or having any other health condition. And so I would just encourage us all to be a part of the change by reflecting internally, looking at our own internalized stigma, and really supporting young people in and listening to them about what they want and what they need, and doing everything we can to provide that in our immediate circle, but in our communities as well.
Thank you, Michelle. Laurie?
Short term, I don't know. I mean, I'm living it, so I don't have answers for the short term. Long term, we have to train more professionals. So perhaps that's incentive on those in college to go on to graduate school for psychology, psychiatry, whatever it might be, but also to encourage them to serve youth. If we address these problems among the youth, that is long term. That means perhaps you don't have to address them as adults, or you don't have to address them the severity as adults. So encouraging more professional or more students to go into healthcare, mental health care for youth will just be tremendous for our long term. Every child should be able to get the help they need when they are in not even crisis, just mental health challenges. And that doesn't exist for us now, and that is unforgivable. So I don't know what we do now. I can't answer that question. But I'm very much a systems change person. I'm very much at the long term and training and have the professionals that we need. But that would be great if anybody on this phone could answer, what do we do right now? How do we help the parents and their young people, the young people in their lives right now?
Dr. Wood, would you like to take that on? And then Dr. Dunlap and Gabii.
Yeah, I will chime in. I agree. I can give you a list of all kinds of long-term solutions and ideals and fantasies. So I tried to write down some things that maybe we could do now. I think part of it is normalizing the conversation for the adults and the children. I'm also sort of a systems-oriented person, and started out as a school psychologist. And I would love and peers are usually the first ones to know when something is going on and not well. And I would love for it to be like everyday practice in a elementary school for a kid to say, hey, have you done your breathing, your mindfulness today? You know,
That's terrific.
right? Normalizing that conversation. And I think related to that is doing more community-based care so that we have an integration of mental health, not just in our schools, but, you know, back to kind of the Black community, like in our barbershops, in our churches, you know, that it is just normal that we have those conversations in the places where people are meeting and congregating. Leveraging social media, I am not the best at this, but, you know, using TikTok and Instagram Live and getting information out, dissemination of information. We have it. We know we have it. We just need to get it out there and maybe not be so proprietary about it. And I think that and empowering youth, I think is something else. But that, again, long-term, short-term, those are my immediate thoughts.
Ulash.
I echo everything my peers are saying. And so thinking very like here and now, you know, our parents need so much support. I'm a parent, I totally get it. So how can we resource parents in our community? That's been a lot of my work, you know, parent support groups, informal meeting up, wherever it might be, is so important. Online resources, I think that's great. And then these peer certification programs that we've been rolling out, because the problem is the pipeline system where everybody needs a master's or some kind of postgraduate training, which is great, but that costs money. So the peer certification program, I love what you said, Dr. Wood, about the peer-to-peer, firstly, youth and children. The peer certification program, we need more of that. And why can't we make master's level programs free or some kind of scholarship so we can have more diversity? Because now the inequities are getting great. Who gets to go to these programs?
Thank you. Gabii, you have the last word.
Wow, no pressure. I think one of the most important things that we can all do right now is just check in with your friends, with your family, with the youth in your life, with the parents in your life. And if someone tells you they're struggling, take it seriously. You know, students and youth get a lot of grief for, it's just hormones. You're just growing up. And like, that's all true, but it continues past, you know, the age of 18. Once you finish puberty, for example, people are still depressed. So, you know, check in on the people in your lives, see what they need, and listen and take them seriously.
Thank you all so much. This conversation has been invaluable. Sandy, do you have any final remarks?
I'm just trying to soak it all in as a grandmother and a mother. I really feel all of us are in this together. I think the most important thing I heard personally was the value of support systems. And the most scary thing I heard was that 8-year-olds are committing suicide.
Yeah.
If that doesn't sound the alarm bell the way it needs to be sounded, I don't know what will, but this has been very informative. Thank you all.
Thank you all. Take care, everyone.